Dr. Kuruparan, for the kind introduction. First, I would like to thank SRCC for giving me the opportunity to bring some knowledge sharing. Good evening, everyone. Today, we will be discussing on the acute LVF. Although this is an age-old term, acute LVF, I was trying to find this word in sort of the latest guidelines and books. It's rarely used these days. So we will try to try to incorporate this word and what really that it means in next few minutes. So initially, we will understand what is an acute heart failure, right? So does acute heart failure means it is acute LVF or is it something else? So acute heart failure by definition is a rapid or gradual onset of symptoms and signs of heart failure that is severe enough to get urgent medical attention, leading to an unplanned hospital admission or an A&E visit, right? So what it says is somebody who can come with a gradual onset worsening symptoms or acute onset worsening symptoms, which need urgent attention and coming to unplanned hospital admission or A&E. So that is acute heart failure, right? So why acute heart failure is so important to know, right? It is a leading cause of hospitalization in people aged more than 65 years worldwide. It's a very high mortality.
Zacky, can I disturb you for a minute? There are about 3 or 4 people saying they can't hear well. Is there anything we can do to make it louder?
Hello, can you hear me now? Is it better?
It is. I can hear, but there are about 4 who have said in the message chat group that it is not very clear.
What can I do? I'm using the usual settings with the
yes.
thing. Aruna, is there anything that you can tell me to help?
Recording stopped.
Aruna?
Is it any better?
I can hear reasonably well. It breaks off on and off, but there have been voice not clear is a message that we have got. About 6 of them have put it in the chat group.
Again, if others can just put another message. So rapid or gradual onset of symptoms and or signs of heart failure, severe enough to seek urgent medical attention. Is it good enough?
I can actually hear, but I can hear, but we will see. Maybe some of
I can suggest is I think use your earphones. That might the people who are not using an earphone might help, I think. Isn't it?
Yeah, we will continue. I think there may be some issues on their internet connection. I'm not sure.
Recording in progress.
Yeah. Might be the internet connection. I'm also using a router. I can't do anything more about it. So we will continue and see if it is very bad. We will try to shift the place and see.
Yeah, we will continue. Yes.
Yeah. So as I said, acute heart failure is the leading cause of hospitalization in elderly people with a high mortality and pre-hospitalization deaths. In-hospital mortality is fairly high. It is 4 to 10%. So sort of 1 in 10 or 1 in 20 is likely to die. The patients who is admitted with acute heart failure, 1 in 10 to 1 in 20 is likely to die in hospital. So it is a pretty bad mortality rate. So now we will see what is really acute heart failure. There are 4 major clinical presentations can be described with possible overlap. We can't say this is the demarcation. It is not black and white, but we can, with the clinical symptoms and signs, we can describe 4 sort of syndromes, right? We will come to that in the next slide. The clinical presentations are mainly based on the presence of either congestion or hypoperfusion of the peripheral hypoperfusion. So the treatment will depend on what is predominant. Is it the congestion which predominates or hypoperfusion which is predominating? Or else sometimes it could also be together. There is a lot of congestion and a lot of hypoperfusion of organ, right? The next slide. So these are the four major clinical syndromes that
Recording stopped.
In the acute heart failure. The red mark, acute pulmonary edema, is sort of the closest topic that I could select today for the acute LVF. But as you can see, it could be divided into acutely decompensated heart failure or acute pulmonary edema, isolated right ventricular failure, and cardiogenic shock. So out of this, I think the most serious one is, I think, the cardiogenic shock. But today, I think we are not going to discuss all four. We are trying to discuss more on acute pulmonary edema, saying that there could be a lot of overlaps in symptom and signs of these four syndromes, right? So if you see acute pulmonary edema, the main mechanism of acute pulmonary edema is, as you can see, it is increased afterload or predominant LV diastolic dysfunction. So it could be valvular heart disease like acute mitral regurgitation or acute aortic regurgitation. So predominantly it is something to do with the afterload, that is the peripheral resistance, or it could be due to the diastolic dysfunction of the heart, right? So that is the main mechanism. So what happens, the main cause of the symptoms? So if they increase afterload, and also if there's a diastolic dysfunction, what is the problem, right? As you know, the left heart is connected to the lungs through the pulmonary veins, right? So the left ventricle is there is mitral valve on top of that left atrium, which is connected to the lung directly with the pulmonary veins, right? So anything happening in the left heart will be reflected in the lungs in a bad way. So what will happen? The fluid redistribution to the lungs and the acute respiratory failure can occur. That is the main cause of symptoms why the patient comes acutely in acute pulmonary edema. So the difference between the acute decompensated heart failure and acute pulmonary edema is, as you can see, the onset and the mechanism. The onset is, although the patients come to hospital with, maybe in weeks or even a few days time, they gradually decompensate and come to the hospital. That is one presentation of the acute heart failure that is called acutely decompensated. But in this case, this is only few hours. A patient can go into an acute MI and they can come with acute pulmonary edema. Or there is an acute anterior MI, mitral regurgitation, patient can come with acute pulmonary edema. Or if there's a severe diastolic dysfunction, patient going to atrial fibrillation, they can come like acute pulmonary edema. So it is within minutes to hours, the patient will come with a severe shortness of breath. We'll come to the clinical syndrome later. So if you go to the underlying main hemodynamic abnormalities, if you take the acute pulmonary edema, the increased left ventricular end diastolic pressure, right? The end diastole, as you all know, once the heart, the left ventricle pumps out of the blood out of the left ventricle, there is a certain pressure, say about, it could be 1, 2, 3, or something like up to 4 might be normal, 4 or 5 might be normal. So that will be increased. So end of the diastole, the left ventricular pressure will be increased. That will be reflected, it is all a connected loop, right? As I said, through the pulmonary veins, it is connected to the lung. If you see the pulmonary capillary wedge pressure, it will be elevated, right? And if you see this syndrome, it is the normal cardiac output, right? The cardiac output will be normal and the blood pressure will be normal or pretty high. I think all of us have seen in the acute, either CCU or A&E, the acute left ventricular failure coming with the pulmonary edema. They are, severely short of breath. They are perspirating. They are gasping for air. Their respiratory rate is high, right? And but their blood pressure, they will be tachycardic, but their blood pressure is pretty normal. And to touch, they will be warm, right? So if you say the main clinical presentation, it is what we call, there is a classification in the next slide I'll come. It is wet and warm refers to the congestion and the perfusion. I'll come to that. So these patients are usually wet, means the lung is very wet. They'll be full of crepitations, right? And the saturations will be low, they'll be perspirating, right? Plus or minus right heart failure might be or might not be there. And to touch, they will be usually warm. So that is why this syndrome is compared to, say, for example, cardiogenic shock, they will be congested, that is wet.
Recording in
and also
progress.
cold. So that is the perfusion is low. So in this case, usually there is a lot of congestion, but there will be reasonably good peripheral load, right? So the management will come in the diabetics, plus or minus vasodilators and support care. The next slide will show you what is this sort of syndrome. Where we say how well the patient is perfused and how well the patient is congested. So if there is a, on the top of this diagram, you can see there's a congestion, minus and plus. The left side of the diagram, you can see hypoperfusion, plus or minus, right? Our patient is, the perfusion is okay. The signs of hypoperfusion size, you know, there'll be a cold sweat at extremities, oliguria, there'll be low urine output, there'll be confused, there'll be dizziness, and narrow pulse pressure. These are the main signs of hypoperfusion. But in our category, it is a both you know, heart has two sides, the left ventricular failure and the right ventricular failure, or even congestive cardiac failure. But in our case, if it is acute pulmonary edema, acute left ventricular failure, there will be a lot of pulmonary congestion. And there will be orthopnea and paroxysmal nocturnal dyspnea, peripheral bilateral edema. So this is talking about the right side congestion. Jugular venous pressure will be high. It's all peripheral, but in our congestion, orthopnea, paroxysmal nocturnal dyspnea, those sort of things. So this categorization to identify these acutely unwell, acutely heart failure patients, these categories are very important. So by assessing their congestion level and the perfusion level, right? Edema. So what is acute pulmonary edema? A condition characterized by fluid accumulation in the lungs caused by extra of the fluid from pulmonary vasculature into the interstitium, right? So how does the fluid accumulate in the lung? The fluid go out of the vasculature of the pulmonary vessels. Where does it go? It goes to the interstitium and also, right? So acute pulmonary edema, as you'll know, could be cardiogenic for the due to the increased hydrostatic pressure in the pulmonary venous system, right? Non-cardiogenic pulmonary edema, as you all know, we will come to some slides. I'll come to that. So it could be exudative. The patient is dyspnea with orthopnea. There will be respiratory failure because there's a lot of fluid is accumulating in the alveoli and the interstitium. Due to that alveolar capillary membrane, this gas, diffusions will be affected. So they will get hypoxia at the same time, hypercapnia.
Zacky, can I just
predominantly type 1.
Zacky, I think you are breaking off frequently. is there a way of moving to a closer to the router or something like that? Is it possible? Because I think you are breaking very often.
Yes. I will try that. I'll try to put my hotspot in a phone and see whether it works, right?
Right. We'll try that. Yes.
So let's see. Hello.
Yes. Yeah.
Yeah. Now I'm connected to my hotspot in the mobile.
Yeah. It seems better. We will try that now. Yes.
Yeah.
We'll continue. Thank you.
Yeah. Okay. Yeah. So the clinical criteria I was telling, the patient will be very dyspneic, orthopneic, and hypoxia, hypocapnia, increased respiratory rate, and the work of breathing will be increased. You can see that by using the accessory muscles and the force of labored breathing and all that. That is due to a lot of fluid accumulate in the lungs, so that the compliance of the lung will be very increased. That is to increase the volume per unit of volume. You need a lot of pressure to, increase the volume of expansion of the lung, right? So this is again just for the interest sake, we have put what are the causes for cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. So the cardiogenic pulmonary edema, it could be systolic heart failure, that is reduced ejection fraction, preserved ejection fraction, valvular heart disease, as I said, like acute MR or acute AR, cardiomyopathy, pericardial disease. All this can cause acute pulmonary edema due to cardiogenic cause. As you all well know that there are non-cardiac causes for pulmonary edema as well. For example, you might have seen 1 or 2 patients with a severe head injury coming with pulmonary edema, sudden airway obstruction, that is the negative pressure, and the toxic drugs, blood transfusion syndromes, contrast injection, air embolism. Likewise, there are a lot of reasons there are non-cardiogenic pulmonary edema that could occur, right? So the next slide will tell you exactly what is this diagram is very easy to understand what is really happening compared to the normal circulation in the lung and how heart is connected. As you see on your left side, you can see the normal circuit. The left ventricle is connected through pulmonary veins to the lung and the alveoli. Normal circuit, all these vessels are in normal size and there is no vasoconstriction or anything. But from the left side, cardiogenic pulmonary edema, you can see that the pulmonary veins are engorged, right? Left atrium is engorged. At the same time, the systemic vessels, the arteries in the vasculature is increased. So that is what we said, there are 2 main mechanisms. One is due to pulmonary congestion, other one is due to the increased afterload. So in this condition, we have the acute pulmonary edema, or we call it acute LVF. Their main pathophysiology lies in increased LV preload, that is increased LV and diastolic pressure, transmitted to the left atrium, that is again transmitted to the lungs through the pulmonary veins. So there's a lot of backup. So the lung can't empty into the left atrium. So lung congestion. Secondly, there's a lot of peripheral vasoconstriction, increasing the afterload, right? So the next diagram, this is almost the same thing, but in a more sort of colorful diagram. And it also differentiates the acute cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. The main difference is, as you all can see, there's increased hydrostatic pressure, and due to that, there's a lot of dilatation and congestion of the pulmonary venules, right? On the other hand, the main mechanism of non-cardiogenic pulmonary edema is due to the disruption of the endothelial barrier, so that it is an exudative fluid will be in the alveoli and the interstitium. On the other hand, cardiogenic pulmonary edema, there will be a transudative or protein poor fluid will be in the lung. So this has a repercussion on the management of both of these conditions, right? So management of, now we will concentrate on acute cardiogenic pulmonary edema, that is acute left ventricular failure in our case. So we need to make some decisions, right? So we need to, once the patient come into A&E, the initial management is done, we have to admit this patient at the CCU, ICU, or it could be in some very rare instances to the ward. So we need to, decide on what we are going to monitor in this patient and what are the investigations that needs to be done on this patient and what is the immediate care, intermediate, and the pre-discharge and long-term follow-up. So these will be the sort of next 10-20 minutes discussion how we are going to do all this. So this is, I'm sorry, a bit of a congested slide. So this is the criteria for CCU or ICU admission. I think yes, a slide is shared already. You can visually go through this and have an idea. So if you need an intubation, obviously patient need ICU care. Poor response to NIV or oxygen therapy, still the oxygenation is not good enough. That is the patient might need any time intubation. So you need ICU care. Signs and symptoms or markers of hypoperfusion like cold extremities, poor mentation, confusion, oliguria. All these things are, now patient is heading toward the cardiogenic shock now, right? With a lot of hypoperfusion, that's indication. We need multiple other intravenous therapies, so we need the ICU admission. Persistent hypertension less than 90, procurement for 2 or more vasoactive agents to maintain the blood pressure. So this all indicates either hypotension or hypoperfusion or poor oxygenation. All these 3 things, 3 or 4 things, which says us that the patient needed more sort of critical care, more invasive monitoring, more close monitoring, and many, right? And requirement of invasive cardiac output monitoring, sometimes we need this. Requirement of mechanical circulatory support, rarely like IABP or ECMO, something like that. Or if the heart rate is bradycardic, or if they have life-threatening tachyarrhythmias, patient needs ICU care. Any associated non-cardiac condition requiring critical care admissions, sometimes we forget. We see only the 2 sort of tunnel vision. There we see only the acute problem. But on the other hand, patient might have, for example, diabetic and ketoacidosis on top of this acute pulmonary edema. Patient might be a end-stage renal failure coming with a venous transfusion or hemodialysis. You might be forgetting all this. So if there's any critical conditions which need attention in the ICU care, that is another indication to keep the patient in care in the ICU. So monitoring-wise, what we are going to monitor. This is sort of everybody knows simple stuff. So if you connect to in the ICU and cardiac monitor, as you all know, there will be heart rate, rhythm, blood pressure, respiratory rate, SpO2. All these things will be with automatically, could be checked in any patients in a ICU or CCU setting. If the patient is able to be mobilized or stand up, you can check the daily weight. We are expecting a daily weight loss of about 750 to 1 kilograms with IV diuretic therapy in these patients. And the weight needs to be measured the same time of the day. That is also important. That is called standardized weight measuring. And the symptoms and signs of congestion and the hypoperfusion, which I discussed earlier, what are the signs of congestion, what are the signs of hypoperfusion, which needs to be documented in the BHD each and every day in your ward round, preferably if it's a critically ill patients 2 or 3 times a day. So daily serum electrolyte and renal function test when the patient is on IV therapy, especially the diuretics and the inotropes and vasopressors. Arterial line, if persistent hypotension or symptoms are persisting despite our initial medical management. And input-output chart, preferably with a Foley catheter or even the condom catheter, it will be better if you can have a catheter, urinary catheter in. So all these things needs to be monitored in patient almost daily and documented in the PhD in your patient. This is, I'm not going to do this is for the completion's sake. I put this slide. Some people, they can forget the very basic things what we are discussing. So I have, added symptoms, signs of congestion and everything. All the definitions are here basically. What is hypotension, what is tachycardia, what is abnormal respiratory effort, everything we have a definition. Although we discuss some of the things, this patient is hypoxic. So if somebody asks what is really hypoxia, they'll be struggling. So what is really hypoxia? So it is a PA pressure of less than 80 millimeter mercury or 10.6 Pascal is the real hypoxia, right? Likewise, what is low saturation? Many of our patients, as you know, once they come to CCU, the nurses, first thing they will do is put the oxygen at 15 liters. It is one thing, the worst of oxygen. Secondly, oxygen is toxic, right? It can damage your lungs, and there'll be a hyperoxia related lung damage is very serious. So oxygen is only indicated once I will discuss that. So what is low oxygen saturation rate? Should be less than 90 in the pulse oxygen, right? So this is just to recapitulate your basic, right? So once this patient is admitted into the ICU or ICCU, what are the investigations that you are going to do? So we have two extensive charts. Again, you can, not all the investigations are done in all patients. So you need to do some of the basic investigations in all the patients. And according to the patient's profile, due to the history, examination, everything, what you find, then you might need to escalate on some of the investigations. So as you all know, ECG is a very basic investigation. Everybody needs to be done an ECG. Chest X-ray is a basic one you need to do. And we have put it here what we are looking for. And lung ultrasound scanning, nowadays it is in our A&E consultants are very proficient, even the medical officers are proficient in lung ultrasound, which can detect, this B lines. And also that is indication for pulmonary edema. And also sometimes they can detect this pleural effusions or even pericardial effusions and things like that, right? Echocardiography, it is again a point of care echocardiography. I think everybody who is caring for these patients in A&E or CCU, ICCU should be able to do a point of care assessment of echocardiogram just to exclude what is the LV function and if there's any major pericardial effusion or something, very basic stuff, right? And this is a topic in itself, but unfortunately, the natriuretic peptides are not widely used in Sri Lanka, although in Colombo, some of the private hospitals we do use. But it has a good value. But instead, the echocardiography is easily available in our country compared to the other nations, other developed nations. To get done echocardiogram might be a little difficult, but they can. Natriuretic peptides are done very easily, right? Cardiac troponins are if you're suspecting acute coronary syndrome or acute aortic syndrome, then you need to do a cardiac troponin. Serum creatinine, again, it is a very vital to do for one thing, the baseline, secondly, the monitoring of our therapy and its side effects, right? And it also has a prognostic value as well. Serum electrolyte, again, daily, it needs to be done in a patient who is critically ill. Iron status, that is, we'll discuss that a little later. Iron status now, if there's a patient with iron deficiency in the heart failure, there is a value of giving IV iron therapy for those patients to improve their symptoms and also prevent hospital admissions. Thyroid, as you all know, thyroid is it can lead to heart failure, both the diastolic and the systolic, and also it can induce arrhythmias, both tachy and the brady, depending on what's the thyroid state. D-dimer, depending on your clinical profile, right? Procalcitonin, again, depending on your clinical profile. Not widely available. Procalcitonin is a specific marker for sepsis, right? Lactate is a basic text. If it is available, it has a prognostic value and it also can guide the therapy, right? So that is a lot of value with the lactate. If you can get it done, that's good. Pulse oximeter, arterial blood gas, these things are again to identify the respiratory failure and oxygen therapy, and these things needs to be done. So those are the basic sort of investigation you need to get done. And regarding this natriuretic peptides, there are loads of causes. Like, as we all know, the troponin rise. There are a lot of causes, non-cardiac and the cardiac causes, which increase the troponin. Likewise, the natriuretic peptide also, there are many causes which can increase the natriuretic peptide, both the cardiac cause and non-cardiac causes. But this is like D-dimer in the pulmonary embolism. It has a great value in patients who are coming with symptoms of heart failure, and their echo is not widely available. Then you can do the BNP. If these values are below these, like for example, BNP less than 100 means you can almost exclude the heart failure. Like this, it is a value, right? And this X-rays, I think for you all very familiar. It is two patients, two different. The right one is a typical sort of wet wing appearance with little bit of edema, pleural effusion, and also there's upward diversion of the lobe. These curly B lines are, it is difficult to detect in these sort of X-rays. We need to, zoom and expand and see those curly B lines. That's usually the horizontal lines on the base of the lungs, that is curly B lines. So these two X-rays, I think you can see it is acute pulmonary edema with a lot of congestion, and one has an enlarged heart, other one has a sort of a normal size heart. So these two are, just ICU X-rays where the pulmonary edema is present. Next, if you see, so what are the sort of immediate in the emergency department, ICU, CCU, what are the sort of goals that we should have? So our goals, immediate goals, are to improve the hemodynamics and the organ perfusion, restore the oxygenation, alleviate symptoms, limit cardiac and the renal damage, prevent thromboembolism, and minimize ICU. And these are the immediate sort of goals we have. How you are going to manage this patient to achieve these goals? So this is again a sort of a flow chart which says how to manage. Initially, you need to administer the oxygen. Depending on how severely they are hypoxic, you can use the face mask or the nasal prongs, or sometimes you might need to do the laryngeal mask, or even further escalation like NIV, like CPAP or BiPAP, whatever, the oxygen needs to be administered acutely. Secondly, the ventilatory support. As I said, even the ventilation, I will come to that. There are indications to get this patient, even intubation and ventilation. So if the oxygen therapy and the ventilatory support is given, then you have to see how is the blood pressure. If the blood pressure is high, that is usually the case in pulmonary edema or left ventricular failure. If it is more than 110, then you can straight away start on the diuretic therapy, right? The diuretic is a class 1 indication, as you all can see, and vasodilators, I think it is mainly in our part of the world, we use GT and infusion. It is compared to the loop diuretics, the vasodilator therapy is not very good in managing these patients. Although if you take the pathophysiology, the vasodilators has got a lot of good effects for the heart, hemodynamics. Unfortunately, in the trials or whatever the study is, the loop diuretics do better than the vasodilators, even if the blood pressure is good, right? So if the blood pressure is low, if the blood pressure is less than 110, then we have to look for the signs of hypoperfusion, right? So if the patient has hypoperfusion, right? If the person has hypoperfusion, that is an indication on top of the loop diuretic. If the patient is already congested in the lung, loop diuretics are necessary, but the blood pressure is now low and that is leading to hypoperfusion. Now you have to consider inotropes, vasopressors, right? This is sort of, as I said, these 4 clinical syndromes. You can't say exactly black and white, this is pulmonary edema only and this is cardiogenic shock only, like that. It is very difficult to say. So this category of patient, now the patient is in pulmonary edema, also hypoperfusion. So this is sort of going into cardiogenic shock. So this patient needs to be administered both the decongestion therapy with loop diuretic and also inotrope or vasopressor, right? So if there is no signs of hypoperfusion, but still the blood pressure is low, you can only administer the loop diuretic NC, right? Next, you have to see whether the congestion is now relieved. Patient is breathing is little better now. Heart rate is going down. Oxygenation is better. Good urine output. So if it is relieved, then you have to continue with the medical optimization of therapy, which will come to. If the patient is further deteriorating, that means the cardiogenic shock, then you need to consider, for example, renal replacement therapy or mechanical support like IABP or something like that, right? So the oxygen therapy, how we are going to do when we are going to administer oxygen, as I said, if the oxygen saturation is less than 90 or partial pressure of oxygen less than 60 millimeter mercury, that's the indication for oxygen. So how it could be administered, as I said, initially you can go with nasal prongs or free breathing mask or facial mask. Later, if this is not picking up, then we have to consider NIV, right? So what is the indication for NIV? If the respiratory rate is more than 25 beats per minute, and saturation is less than 90, but despite that, administration of oxygen previously with a nasal prong or face mask. So reduce the rate of mechanical, so the NIV is definitely reduce the rate of mechanical endotracheal impedance. So the intubation rates are low with, if you start the NIV early, it will reduce the intubation of the patient. So what are the indications for intubation? Again, it's a sort of a long list. Cardiac respiratory arrest, obviously. Progressive worsening of altered mentation, so that patient can't maintain an NIV. That is indication for intubation. Progressive worsening of respiratory failure with hypoxemia or hypercapnia or acidosis, right? Despite NIV, that is an indication. Need for airway protection, like low GCS, less than 8 GCS patients. Persistent hemodynamic instability, agitation or intolerance of NIV with progressive respiratory failure, all these are indication. I think the most important indications are on top, when it is coming the down and down, the less important ones are coming. Next, we have to see what are the pharmacological agents or supports that we need to administer in these patients acutely. IV diuretic therapy, as I said, it is the backbone of the treatment. So if there's a vasodilatation, as we discussed, low blood pressure or reduced, if the blood pressure is very high, and if there's afterload is also high, for example, hypertensive patient in the echo, there is a lot of LVH, there's a lot of diastolic dysfunction, you need to reduce the afterload. The initial slide, as I said, there'll be a pulmonary venous congestion, but the peripheral arterial constriction. So the afterload is due to arterial constriction. So if the arterial constriction is a very high blood pressure and the reduced afterload is very high, then the vasodilators are indicated. Inotropic agents or vasopressors, if persistently low cardiac output, hypotension and low perfusion, that is the indication to use these inotropic and vasopressors. Digoxin, IV digoxin 250 to 500 mics you can use for fast AF, provided there's no renal failure impairment. You need to be very careful about electrolytes. Thromboembolic phenomena, this is one thing we try to forget in our patients. We do see a lot of pulmonary embolism after prolonged bed stay and dehydration of these patients. So each and every patient who is coming with this acute heart failure needs to be on a prophylactic dose of enoxaparin or heparin, or even if those are contraindicated, then you need to put a pressure socks. Opiates, it is a sort of a controversial area. I'll come to that, or whether we are going to do morphine, because morphine we regularly use in those days with acute LVF patients. We use morphine very regularly, but nowadays we don't use morphine that much. And this is now the algorithm for the loop diuretic usage. So the patient, the management of diuretic therapy with acute heart failure. So patient is, if already on the oral diuretic, then patient, the dose of IV diuretic needs to be 1 to 2 times of that daily dose. If the patient is already on oral diuretic, patient is coming with acute pulmonary edema. Say, for example, patient was on 40 milligram furosemide twice daily, so the total dose is around 80. We might need to give 160 dose. it needs to be divided in 2 doses and give something like that, right? So if the patient is not already an oral diuretic, then the initial dose is start with a lower dose. For example, 40 to 20 to 40 milligram IV. Then you have to check spotty urinary sodium, but unfortunately, I don't think it is widely available in our setting. But we can see the urine output. If the urine output is good, more than 100 to 150 ml per hour, that is a good diuresis, right? So in that case, you need to repeat the similar dose every 12 hours. So that is a BD dose you can do IV diuretic. Sorry. Yeah. So if the patient do not have adequate urine output, why we are checking this urinary sodium is, as you know, in small age in the medical school, you have learned the heart failure pathophysiology is renal angiotensin response system. Basically, it retains fluid and the sodium. So we need to take out both the sodium and also the water out. That is why we are checking all this. So if the patient doesn't have adequate urine output and adequate sodium wastage, then we need to double the dose of IV therapy until the maximum IV dose. Prosimide, they say it is a very safe drug. You can go up to even 1 gram, right? Some of the guidelines say even 1 gram could be used, but our usual dose is around, say, 200 to 300 milligrams, right? So if again, you need to recheck your urine output and the urinary spot sodium. So if your target is achieved, then you need to continue until the complete decongestion is achieved, right? Then the check urea creatinine, the renal function every 24 hours. And the combination, if the patient is not achieving adequate urine output, then there's this concept called sequential nephronography. So we use the loop diuretic first, then you can sequentially add, for example, you can add thiazide diuretics, later on spironolactone or eplerenone, likewise you can add on, right? So that is the diuretic management of this patient. My slides are moving very slowly, I don't know why. Sorry, the slides are moving slowly. This is, I think, nothing to discuss. This is for the completion sake. If somebody wants what is the doses of IV vasopressors and inotropes, these are the chart, but will be a separate lecture on inotropes and the vasopressor therapy. So I'm not going to discuss this in this lecture. So that is the acute management that we have discussed in ICU, CCU. Then the intermediate, once the patient is stable, what are the goals or what are the things that we are going to concentrate more? So it is identify the etiology and the relevant comorbidities are very important. Titrate therapy to control symptoms, congestion, and optimize blood pressure. But we have started, we need to optimize our therapy according to the congestion and also perfusion. And the initiation of the initiate to uptitrate the disease-modifying pharmacological therapies. As you know, the heart failure long-term, there are a lot of medical therapies that needs to be there. Like, for example, ACE inhibitors, the guideline-related beta blockers, right? Diuretics, mineral like spironolactone sort of medicines. So there are a lot of medicines which needs to be there on a patient with heart failure. Those all needs to be assessed. Either we need to, if the new patient, we need to initiate, or if the patient is already on those medical therapies, we need to go for the maximum tolerable dose. And we need to also sometimes consider the device therapy as appropriate, for example, CRT or whatever it is. Right. So what are these acute etiologies that we are talking about, which needs sort of acute attention? So the acute etiologies which need sort of immediate action, that is after we manage a very acute situation, then we need to concentrate on this, which is CHAMP, there's pneumonic. So whether there is any acute coronary syndrome. So you have already taken the ECG, you have already taken the troponin, then you know whether there's acute coronary syndrome or not. So if it's ST elevation MI patient is acute left ventricular failure, patient is a class 1 indication to take to the cath lab if it is available, right? Or at least thrombolysis. So if the patient has hypertensive emergency or any malignant arrhythmias, very fast AF, VT, VF, whatever it is, or mechanical causes. Mechanical causes I on the right side put up what are the main sort of mechanical causes in the heart which can give rise to acute pulmonary edema. So it could be a free wall rupture, very blink chance of getting a survival after the left ventricular free wall rupture, but still, if they put a table immediate angiogram surgery, there are patients who will survive. Acute VSC after MI, it is a very, very, very acute thing. Again, the mortality is very high. We need to act very fast. Sometimes patient can survive. Anyway, the mortality is very high. Acute MR, again, the same situation. Chest trauma, cardiac interventions, right? After that, there could be some, say, for example, temperament or something. Acute native or prosthetic valve incompetency secondary to endocarditis. So sometimes patient coming with after a few weeks or within the first 6 months of the surgery, patient come with endocarditis or undercoagulation and acute thrombus, acute aortic dissection or any other thrombosis. So all these things are acute mechanical causes which can give rise to cardiogenic pulmonary edema. Pulmonary embolism, infection, and tamponade, all these are acute etiologies which are sort of reversible. There is therapies and medicines and treatments available, right? So all these things needs to be identified and immediately acted upon. So other common precipitating factors of heart failure hospitalizations are like acute infections, non-adherence to medicines and diet, they're eating a lot of salt or something, or taking loads of fluids, likewise. Or if there's anemia due to any reason, hypothyroidism, medication that increase the sodium retention like NSAIDs, right? Or medications which are negative inotropic, for example, if the EF is very low, some patients are getting diltiazem or verapamil or something like that, right? All these things are precipitating causes which in the hospitalist stay, we need to identify and correct. Then during this intermediate phase, the guideline directed medical therapy during hospitalization, the oral this therapies should be continued and optimized on admission. As doing so is associated with low post-discharge death and readmission. As I said, for the diuretic therapy and all, there is no major mortality benefit. But this guideline-directed medical therapies like ACE inhibitors or beta blockers or ARNIs, or there are a lot of things which has both mortality benefit, morbidity benefit, and readmission benefit as well. So we can't just do the acute management and forget about all these and send the patient home. So we need to have a list of medicines or checklist where if there is no contraindication, all these heart failure medicines should be there, right? And also the liver thing, as you all know, this dapagliflozin or empagliflozin for heart failure with reduced ejection fraction, even without diabetic, those medicines should be there nowadays unless there's a contraindication. And the latest trials say even for heart failure with preserved ejection fraction, there is benefit, right? So on admission, continue the guideline-directed medical therapy unless contraindicated. As an inpatient, continue diuresis despite mild reduction in the renal function and the blood pressure with all this guideline-directed medical therapy. On the pre-discharge, before discharge patient is getting ready, you need to reinitiate. If something is stopped due to, say, very low blood pressure, you stop the ACE inhibitor, you need to reinitiate. Or optimize. If the patient is already on a low dose of ACE inhibitor or beta blocker, you need to go for a higher dose, higher tolerable dose, right? Once the patient is clinically stable. There are some special situations. For example, consider these discontinuation of beta blockers in patients with a very low cardiac output or severe volume overload or advanced AV block. Beta blockers might need to be temporarily withdrawn till the patient gets stability. ACE inhibitor and ARNI therapy, if there's a definite angioedema, then we need to stop. Or if there's a renal function very rapidly deteriorating, more than 50% baseline increase within 48 hours, or if the potassium is more than 5.5, and in these situations, these things needs to be stopped and restarted. VTE prophylaxis, as I said, the enoxaparin or heparin therapy or the mechanical ones needs to be there in these patients during the hospital stay till fully mobilized. For the pre-discharge and the long-term follow-up, we need to have a care plan. Right? We need to have develop a care plan. They are scheduled for up titration and monitoring of pharmacotherapy as outpatient. And need and timing of the review for the device therapy, for example, CRT. Who will see the patient for the follow-up and when? Whether it's a consultant, ideally after the discharge of this patient, a consultant or a senior registrar available, they should see the patient within first 2 weeks. Enroll in the disease management program, education, or initiate appropriate lifestyle adjustment. This is called cardiac rehabilitation therapy, where we establish whenever there's a cardiac unit, we need to establish cardiac rehabilitation units where we can educate all these patients. And we need to have plan for prevention of early readmission with the medication adherence and the food control and the volume control and many things, prevention of infections, vaccination, so many things we can do to prevent readmissions and improve symptoms and quality of life and survival. We have a lot of patients with EF 15, 20, but they have almost normal life with guideline directed optimal medical therapy, sometimes with device therapy on top of that. So what are the things that pre-discharge as a doctor that we need to be assessing? We need to exclude congestion. The patient came with congestion, now we need to say there's no congestion, right? Or minimal congestion. Optimize oral medication we discussed. Make sure evidence-based medical therapy is started or increased, that is also we have discussed. Early outpatient review 1 to 2 weeks to reassess, that is again we discussed. This is the one therapy that I was talking about. If there's an iron deficiency with the ferritin less than 100, or if it is less than 100 to 200, if the transferring saturation less than 20 or something, you need to give IV ferric carboxymoltics. So that has a beneficial effect on both quality of life, symptoms, hospital admissions, some say even mortality. So that summarizes our lecture today. I'm happy to answer if there's any question. There's a very elegant panel with Dr. Gurubaran and Anura also with me to help. It's up to the audience now. Hello.
Yes. If there are any questions, please raise your hand. Then you can mute the mic and ask the questions. I think some had difficulty in got disconnected and then had difficulty in reconnecting. The voice was clear after switching to the voice was clear after switching to the
that was hotspot. So
yes, hotspot. Yes. Any questions from the presentation? Yes, Buddhigali and again. Go ahead, please. Please unmute the mic and ask the question.
So what about sorry, I will ask later. Sorry.
I didn't hear you.
What about the spironolactone in heart failure patients? Role of spironolactone in heart failure?
Yeah, I think, as I said, we discussed about the acute pulmonary edema, or what we call acute left ventricular failure. It is sort of second or third line therapy. If you do not achieve adequate diuresis, then you can see at the slide that I discussed about the diuretics on the right lower corner. We say that I was talking about sequential nephron blocking. That is the combination therapy. So the first evidence is for the loop diuretic. In our country, it is mainly the furosemide, furosemide. Then if you do not achieve adequate urine output and the urinary sodium excretion, then you can try on thiazides or mineralocorticoids like spironolactone. It's oral therapy only we have. But for the chronic heart failure, there's especially chronic heart failure with low ejection fraction less than 40, that has a strong indication in combination with other therapies like ACE inhibitor or ARNI, beta blocker. The mineralocorticoid like spironolactone comes very high in the list. But in the acute heart failure, it is in a sort of second, third level medicines where we can use it as a combination therapy to achieve adequate urine output. Or if the patient on low sort of loop diuretic and thiazide, sometimes they develop hypokalemia. So this is a good way to counter the hypokalemia, starting with the mineralocorticoid. So those are the two main things in the acute heart failure I can think of. Chronic heart failure, yes, if it is a low ejection fraction, it's indicated unless it is contraindication.
Thank you, sir.
Yeah.
Yes, Dr. Arosha.
So most of the time, patients are restless when they are presented acutely. So you said you will talk about morphine and when we should administer it and when should we avoid. Can you please explain, sir?
I say there was some problem moving the slides. I think I got that opiate slide. Current in 2021, PSC and the 20 association, what they say is opiates are very good anxiolytics and sedatives. Even pulmonary vascular dilation. But unfortunately, what they have found in the sort of observational studies and registries are, once you use morphine or the opiates regularly, there are chances of intubation. The risk of intubation has markedly increased, and also the risk of ICU admission has increased. And in some observational studies, even the mortality has gone up, right? So the routine use of opiates like morphine or diamorphine in acute heart failure patients. But there are, say, for example, if the patient is markedly restless, can't do anything, so much anxious, right? So in this selected group of patients with very careful monitoring of respiration, ventilation, then you can use the very smallest possible dose of morphine for the shortest possible time period. Right? So overall, it is a good medicine for acute heart, not a good medicine for acute heart failure. But in selected patient group, where there's a lot of restlessness or anxiety, yes, with very careful monitoring, you can use.
Is there any other drug which we can give just to sedate him or to calm him down? Something oral if the patient can take.
For such patients are midazolam, right?
Okay.
For acute situations, if you want oral medications like alprazolam or even diazepam, that is again, as I said, you need to have a balance. So because these medicines are not going to improve their what is called the mortality rates or hospital treatment, sometimes can worsen. Say, for example, diazepam very large dose can have some respiratory problem. Acute situation, midazolam low dose might be a very good medicine. That is what the guidelines say. Specifically, midazolam is a short acting, a good medicine. Or if you to do some oral therapy for the night, you can use the other medicine. That's been like alprazolam or diazepam even at a low dose and short.
Okay, thank you very much, sir.
Yeah.
Dr. Gunavardhana, please unmute and ask the question.
So the question I have is, now when the patient is on furosemide, how do you monitor the hydration status of the patient?
Clear, I
The
couldn't.
hydration status of the patient as the furosemide goes on. So, sorry.
Can you
Can you
please
hear me now?
repeat the question, Gunavardhana? It was not very clear.
Yeah, I want to know how can you monitor the hydration status of the patient?
Monitor the hydration status.
Hydration.
Yeah, because with the furosemide, if the patient gets dry, and how do you, how do you prevent that, or how do you monitor and prevent that from happening?
Yeah.
On high furosemide doses.
A good question. As I said, I think during my talk, I briefly said, our expert, if the patient coming with acute congestion, our rate of taking of fluid is, say, the daily weight, if we can make it about 750 grams to 1 kilogram, that is our target per day maximum. Secondly, acutely, as I said, the urine output should be about 100 to 150. Then you can look for the electrolyte and the renal functions, whether they are deteriorating, that is another one. And the clinicals, of course, the clinical signs are the much more. Once they are, this patient group is called warm and wet. Their perfusion is good and they are congested. So what are the signs of the wetness? Right, the pulmonary congestion is the main issue. So there will be a lot of crepitations, a lot of rares, patient will be breathless. So once these signs are getting off, then you need to titrate with the urine output, symptom and signs of congestion, symptom and signs of perfusion, dehydration signs, renal functions, daily weight. With all these parameters, you have to come to a conclusion. What is the hydration status of the patient? Once this hydration status is, try to make it euvolemic. If the patient is euvolemic, then what you need to do is you need to now tail off the IV loop diuretic or diuretic therapy and establish on other medications and try to convert oral so that you maintain this euvolemic. It is a fine balance. Even the diet contributes. For example, although the latest guidelines say it is a bit of controversy. I do not want to crack here. The latest guidelines say the amount of fluid intake and the salt doesn't have a major effect on whatever it is if the kidney function is normal. But for acute patient, it needs to be carefully monitored. So it is the answer to your question is maintain the look for your urine output. If possible, have a daily weight. Get the renal function test. Get the signs of congestion and the perfusion and dehydration. These are the 6 things that you can determine how to, what is the input output and how much of diuretic this patient needs.
Thank you.
Can the IVC size also help, Dr. Zacky?
Yeah, that is one thing. If the patient has congestive cardiac failure, that is what I said, there are clinical syndromes. Now we are talking mainly about acute pulmonary edema. So if there's an involvement of the right heart or congestive cardiac failure, in that situation, we monitor the fluid status by IVC. So where some people point of care ultrasound, they can do this one. No, as cardiologists, we frequently do the the ICU or the A&E patients. We frequently say the fluid status with the IVC, where the hypervolemia is defined as a IVC. We need to put the M mode about 1 centimeter into the IVC. 21 millimeter, and the respiratory variation is less than 50%. That indicates hypervolemia. So that is, yes, that is a good indication for intravascular hypervolemia. Then you can also say, for example, if you want to do investigation, you can do the chest X-ray and see where the pulmonary edema is clearing. You can do the lung ultrasound and see curly B lines are disappearing, or the pleural effusion is disappearing. All these things, it's a sort of a combination decision. This fluid status is one of the mainstay of acute heart failure management. So it needs to be meticulously done with multiple parameters rather than taking one parameter. Anything else?
Anyone else wants to ask any question? I think that's all. Buddhika Lianage has raised.
No, sir, you asked earlier, sir.
Right.
Not this time.
Yeah, that's okay. Thank you. So, in the absence of further questions, we will come to a conclusion of this presentation. Thank you very much, Zacky, for your excellent presentation. There were some hiccups in the beginning due to the internet connection, and I think some of you logged out and couldn't get in. Sorry about it. We will try to overcome these issues as we go along. So thank you very much. We will see you all. We will meet you all again next Tuesday for the 4th lecture. Thank you, Zacky.
Yeah. Thank you very much.